15th Lourdes Manahan Lectures in Rheumatology is now streaming live from the University of the Philippines, Manila, Manila. I am Dr. Paulo Lorenzo of the Division of Rheumatology, UPPGH, moderating this session. I would like to thank our sponsor, Pfizer, and all our participants for joining us today. Please post your questions at the Q&A box and we will address them during the open forum. You will receive your certificate of attendance a week after you submit the evaluation form and post-test. The link will be posted later. This is the sixth of our 8-part LMLR series for this year. The LMLR series aims to teach the basics and updates in rheumatology, an advocacy initiated by Dr. Lourdes Manahan, the first Filipino rheumatologist. LMLR is in support of Sustainable Development Goal number 3, health and well-being, and Sustainable Development Goal number 4, quality education of the World Health Organization. The Division of Rheumatology is happy to announce its publication of the book Atlas of Rheumatic Diseases in the Philippines. Those who wish to avail of the book may email pgh.rheumatology@gmail.com. Soon to be published is another book, The Physician's Guide to Tele-Rheumatology. It is a toolkit for the non-rheumatologist on the approach to the initial diagnosis and management of various rheumatic diseases. You may also email to reserve your copies. Our lecture today will focus on rheumatoid arthritis and juvenile arthritis. We are deeply honored to have two distinguished speakers. Our first speaker is Dr. Michael Tee. He is a professor of physiology and rheumatology at the College of Medicine, UP Manila, where he also serves as the Vice Chancellor for Planning and Development. Dr. Tee is the current convener of the APLR Special Interest Group in Genetics and is the chair of the Philippine Rheumatology Association Special Interest Group in Genetics. Our second esteemed speaker is Dr. Cherica Tee. She completed her pediatric rheumatology fellowship at the Philippine General Hospital. She is an associate professor of the Department of Pediatrics in UPPGH and the current training officer of the Division of Rheumatology, Department of Pediatrics in UPPGH. Ladies and gentlemen, let us welcome our husband and wife team, both expert rheumatologists, Dr. Michael Tee and Dr. Cherica Tee, and listen to their discussion on rheumatoid arthritis among children and adults. Thank you.
Thank you, sir. Wait, I have the wrong slides. Here. Good afternoon, everyone. And I'd like to thank our division head and Dr. Paulo Lorenzo for the introduction and for this opportunity to present on the topic of rheumatoid arthritis in the elderly. During the Jubilee celebration of Lourdes Manahan, I presented the updates in the diagnosis and management of rheumatoid arthritis. So now, I'd like to look at the clinical presentation and talk about treatment considerations when we manage the patients who were once young. The objectives would be to discuss the characteristic clinical pattern and then see how we can balance treat-to-target approach with the comorbidities and polypharmacy associated with being an elder of the population. I'll show this again. RA is a chronic inflammatory autoimmune disease associated with autoantibodies to modified self-epitopes. And this is how it would look like. Swelling of the PIP, small joints of the hand, the ankle. You'll see here in the from D to G progression of bone destruction. And then here, I'd like to just show the ACR-EULAR 2010 RA classification criteria, which we use. Having established the diagnosis of RA, we now look at the clinical features of elderly onset RA. I find this interesting because here it is said that age of onset is an important influence of outcome in RA. It is not surprising, and one thing that we have to consider is when we diagnose elderly onset RA, we must be sure that we are not dealing with other diagnoses, many of which would be those with polyarticular crystal deposition disease, osteoarthritis, and even malignancy associated with arthritis. This is among those enumerated in this paper in 1994. When we talk about polyarticular crystal deposition disease, most common of which would be gout. Gout can be due to menopausal stage in women, and then some would be drug-induced, like those taking thiazide diuretic, and also those taking anti-TB drugs like pyrazinamide. 30% of the elders may have positive rheumatoid factor. And erosion on radiograph is quite common, and some may mistake the gout erosion as RA-associated erosion. Another is CPPD, or calcium pyrophosphate dihydrate crystal. And 5% of this population will develop chronic polyarthritis. 10% would have positive rheumatoid factor. Again, because of the subchondral erosion without radiographic chondrocalcinosis, a non-expert radiologist may misinterpret it as an RA type of joint erosion. And even rheumatologists, when they see no crystal in the synovial fluid or tissue, may say, oh, this is not CPPD, this is probably RA. So those are the kinds of misinterpretation and misdiagnosis that can happen. Another important differential, and probably the most common, would be erosive hand osteoarthritis. It has many overlap in terms of presentation with women having rheumatoid arthritis, most common in women. It is the most aggressive form of hand osteoarthritis. There is joint damage, disability, and reduction of quality of life associated with it. The onset is acute as opposed to the chronic type, insidious type of onset, and you will find swelling and redness. On X-ray, you'll find central erosion and sometimes, or rarely, ankylosis. So if you just read this and not read the title, you'll say, oops, that's not osteoarthritis, that's RA. And when you look at the pictures, it's really difficult to differentiate, except that for someone probably as an expert like Professor Penserga would immediately tell us, oh, look at the DIB first, look at the CMCP, and then say, That's hand osteoarthritis. But to the untrained rheumatologist even, or not too expert in handling this, then you will miss the possibility that this is just erosive hand osteoarthritis and say that's seronegative RA. So in distinguishing the presenting features of elderly onset RA with younger onset RA, it would be important to note that morning stiffness, same, fatigue would be the same, but here you'll note that large joint is more common among patients with elderly onset RA than those with young onset RA, such that shoulder is an important manifestation. Subcutaneous nodule is less common, but you'll find ESR to be elevated in these patients more often than those with YORA, or YORA meaning young onset rheumatoid arthritis. Now, positive rheumatoid factor is less commonly found in those with adult onset rheumatoid arthritis. So in this paper in 1985, you might say it appears that having elderly onset RA results to better outcome. Because here, after 2 years of follow-up, they found that morning stiffness is now less common among those with elderly onset RA. Fatigue is less common. There are more patients with lower total joint score, and small joint is no longer as affected, and also only 1% would have large joint disease. But let us remember that this is 1985. The difference, there is not much aggressive treatment for young onset rheumatoid arthritis. So it cannot be said that what happened in September 1985 will still be the same as what it is now in the 2020 decade. In fact, when you look at the pro-inflammatory cytokine profile of patients with elderly onset and compare them, in the demographic data, you'll note that PMR-like symptoms is more common in YORA. And then there's large joint disease onset, which remains, and that erosion is now more common among those with elderly onset RA, while RF positivity remains the same. Meaning, the outcome is changing. And when you look at the reasons, it is because IL-6 may be higher among patients with A-YORA compared to Y-YORA, or young onset RA. And then TNF, elderly onset RA have lower TNF alpha compared to young onset RA. And these are important cytokine activities which can help guide treatment. And it is actually guiding treatment of patients with either elderly onset or young onset RA. Remember that in evaluating patients with young onset RA versus adult or elderly onset RA, you have to make a balance. Are you going to face the risk related to the treatment, or are you just going to allow these patients to deteriorate in terms of quality of life and pain? So considerations in the management of elderly onset RA would include immunosenescence, environmental exposure, genetic association, biologic age, and treatment option. Immunosenescence is an important issue. Patients without RA would have lower immunosenescence, meaning they will have more T cells dividing, T cells that are active, as opposed to those with RA, because those with RA would have more immune senescence or senescence of the T cells. Therefore, the production of younger new T cells would decline, and that will reduce immune tolerance. Meaning these old cells, because they have telomeres shortening, are poorly repairing the DNA and would lose the CD28 signal, and therefore would be called CD8 negative T cells, would be there to attack what they are not supposed to attack. They become autoimmune. That's why in T cell aging in RA, the accumulation of clonal CD4 T cell population that do not have CD28 or CD28 null T cell is an important concept. And this is what is found in the atherosclerotic aorta. And maybe that is the reason we have elevated risk for coronary artery disease and stroke among patients with RA. There is, as I mentioned, shortening of telomere, therefore T cells are dying. There is increased DNA breakage, activation of DNA response, and then metabolic reprogramming. So if we are going to put this in one picture, we'll see that elderly onset is more acute. We usually say RA would develop over months, but here it is acute, meaning some patients would just wake up one morning with polyarthritis and morning stiffness. They have more systemic features, more PMR-like symptoms, and large joints are involved. And as opposed to what is said in the 1985 paper, they now have worse outcome. It's not because there was deterioration in treatment, but rather from 1985 to the year 2020, there is an improvement in the way we manage young onset rheumatoid arthritis. We became more aggressive in terms of starting immunosuppressant, immunomodulator. Methotrexate became an anchor drug, and biologic agents became an important armamentarium in the management of RA. The biologic profile of elderly onset RA would have higher IL-6, lower TNF-alpha, which makes the first line, TNF-alpha inhibitor, perhaps less active in the treatment or less effective. But is it really? Is that a theoretical loss of efficacy, or are we going to see it in trials? That's a question that we'd like to come back later. There's less rheumatoid factor and higher ESR. Now, higher ESR is important in a sense that we use that to monitor treatment improvement. We use that in DAS28 ESR. That's why in elderly onset RA, if you want to monitor for remission, it would be better to look at CRP rather than ESR. So demographic of elderly onset RA, 1/3 would have RA, of those with RA, and the onset is after 65 or 60, depending on the literature that you are reading. And the problem with the elderly RA population, whether they are elderly onset or young onset who survived the disease and grew into a elder stage, would be the comorbidities, polypharmacy, cognitive dysfunction, depression, and falls, which can be seen as the geriatric syndrome. Now, talking about the different environmental exposure, one important factor is smoking. Right now, the 60 years old that we are treating are those born in the 1960s and maybe had their teens they had their teens in the 1970s. And during that time, it was the moment in our history when the smoking practice peaked. So that's why we can say that these elders had their exposure. More of them had their exposure. Right now, it's only 28% of the population of the Philippines that use tobacco, with men being 48% and women only 9%. But during that time, the use of tobacco in the Philippines went up to about 50%, same as those in the United Kingdom. So that induced inflammatory response. There's immune suppression, there's alteration of cytokine balance, and DNA damage that resulted in the formation of anti-DNA antibodies. In a meta-analysis, the risk associated with smoking, cigarette smoking, has been found to be twofold, or 2.02. And to those who know how to read this, you would look at the lines and say that it does not touch unity. So it is truly a higher risk factor. So smoking is established as a risk factor for the development of RA. Genetic associations for early RA, it's DRB104, while in late onset, it's DRB101. And HLA association with RA differ with respect to age onset. So is that something that we can explore? Perhaps, but it's too early to look at that because many of the genetic studies have not confirmed that. Another is biologic age. I've talked about geriatric syndromes, comorbidities, polypharmacy, and frailty. Here in the demographic data characterizing a comparison between young and elderly RA, note that cognitive impairment is significantly different. Depressive symptoms, both would be depressed, whether you're young or old, because of the joint pain. They would have similar incidence of depressive symptoms. Fall, more common among the elder. Urinary incontinence would be common among the similarly not statistically significant, while the HAC, you'll note that the elders have a higher value in terms of health assessment questionnaire response. Then, if you compare now the subjects with and without geriatric symptoms, meaning those who have positive cognitive impairment, depressive symptoms, fall, urinary incontinence, and risk of malnutrition, you'll note that they have higher DAS 28, meaning they have higher disease activity score. Their albumin is lower, meaning maybe they are more inflamed, and number two, may also be related to malnutrition. Hemoglobin is lower, they have higher score in the health assessment questionnaire. Another would be looking at comorbidities. Comorbidities are important considerations when we look at the treatment options available to us. Like for those with cardiovascular disease, we think atherosclerosis and elevated CRP, then we have to make sure that we do not give NSAIDs that are associated with increased risk of heart attack. For infection, age by itself is already a reason to be at risk for infection. But because of RA's ability to cause you to be immobile, then you're at a higher risk of infection. And especially UTI, if you just you will be elderly, lying down on bed in diapers because of the pain associated with walking, standing, and just doing activities of daily living. And then we are going to give them methotrexate, azathioprine. Maybe there is an immunomodulation that can increase the risk of infection. So we have to be careful about that. In terms of malignancy, these patients that are high risk of lymphoma and lung cancer, that's already established. And lung disease, even now, the Division of Rheumatology and the Division of Pulmonary Medicine of PGH are working together to identify patients with ILD at an earlier stage, because we think that if we identify, monitor, and detect any change, then we should be able to prevent the worsening of ILD. And again, COPD is associated with the smokers with higher risk of development of RA. Another thing is COPD is associated with the frailty and sarcopenia that we found out in our own paper published maybe 3-4 years ago. Finally, polypharmacy. There's drug interaction and adverse events that we have to be careful about. In an algorithm, we can say that those without frailty and with successful aging with RA, then we can just treat them as the usual. But those with comorbidities, then we try to prevent frailty, because if we reach an irreversible stage of functional decline, there will be falls and fracture, pressure ulcer will set in, delirium, incontinence, and malnutrition that results to higher risk of mortality. So I would recommend that we follow this paper of Serhal in treatment as a treatment option. No? Those with elderly RA. At low risk, we just treat to target. They are the non-frail, those without comorbidities. But if they are high risk, we try to tailor comorbidities according to cardiovascular, infection, cancer. If you have a patient with liver or renal lung disease, then you might have to decrease or adjust the dose of methotrexate. In those with infection, you should be careful in just giving higher dose of corticosteroids. And those with cardiovascular disease, I mentioned, should be careful in giving NSAID, while at the same time making sure that we treat the cardiovascular comorbidity. We treat the hypertension, we treat the dyslipidemia, and not just say, oh, we'll let your cardiologist do that. Maybe, but as internist rheumatologists, we are capable of, as long as we are capable of treating that, adjusting our diabetes medication, then our patients will benefit. And if you look at the comparison of clinical data in patients with young and elderly onset RA, we'll see that elderly onset RA have the first DMARDs as methotrexate, 85.7%. They have say almost what you call this, they are given the first DMARDs as methotrexate, anti-malarials, sulfasalazine, and some others, while those with young onset RA are more freely given biologic treatment like anti-TNF. So you see. But is it really true that you'll just give biologic agents to the young onset RA? Will the elder onset RA patients not benefit from the advanced biologic agents? Here in this review, the role of biologics in the treatment of elderly onset RA, you'll note that there is similar improvement for both treatment arms, for infliximab or adalimumab versus methotrexate or methotrexate alone. So slightly less improvement in physical function for both arms in etanercept versus methotrexate, similar improvement for methotrexate and etanercept versus methotrexate, slight less improvement. And these are when you compare the elderly RA. No? So again, elderly RA, YORA, elderly RA. And what you will see would be almost all will say similar improvement in disease activity and physical function. In terms of treatment, we recently reported the use of SMI, or superb microvascular imaging, in monitoring rheumatoid arthritis in an elderly patient. This patient is 60 years old and was given a biosimilar infliximab. And we'll just look at the pre and post treatment. And we noted that in this patient who received an elderly onset RA, who received biosimilar infliximab, that on monitoring using SMI, we were able to find that the biologic agent resulted to the kind of improvement that we are looking for. And we were able to document that using SMI. Future, we don't know. We are still writing this paper, the utility of powered Doppler and SMI in evaluating adult Filipinos with active RA. Maybe this is the way of the future. But note that the swelling by clinician in blue and red are almost comparable with the PDI. It's just that SMI, superb microvascular imaging, is really better at detecting swelling and tenderness, because like here in the elbow, using PDI is as good as a clinician evaluating swelling. And in the left wrist, the clinician found it more often than the power Doppler. So in some, like right wrist, I would say that in wrist ultrasound, the clinician is better than the PDI. So maybe we have to move from PDI because it is not performing as well as it should to SMI. That will be the recommendation of this paper, that we're trying to find time to write as a full paper. With that, I hope that you are now able to at least characterize the clinical pattern. They are those with higher ESR, more acute onset, more males than females, and large joint affected more often. And in balancing treat to target approach, we consider comorbidities and polypharmacies. And with that, I hope we can all manage RA patients who are now elders, whether they are elder onset or who have aged well, having RA treated properly in their younger years. Thank you very much. And again, good afternoon.
Good day. I
Good
want
day. I want
to
to
congratulate the
congratulate
Division
the
of
Division of
Allergy, headed by Dr. Evelyn Salido, for its accomplishments and continuously providing education through this Lourdes Manahan lecture series. And thank you for this honor to be invited to talk. Next slide. My main task today is to differentiate juvenile idiopathic arthritis from rheumatoid arthritis. I asked the organizers to let Mike present first. Well, because he was my consultant when I was a fellow. He taught me, so we have to listen to him first. Now, seriously, Mike reintroducing RA to the audience will be a good jump off point for me. And I will complicate it a little bit. Next slide. Let us start with the definition of JIA. Juvenile idiopathic arthritis is a diagnosis of exclusion defined as the presence of arthritis of unknown etiology that begins before the age of 16 and persists for at least 6 weeks. Because JIA was previously known as juvenile rheumatoid arthritis, many people assume JIA is simply a child version of adult RA. Though JIA and adult RA are both forms of inflammatory arthritis, these two conditions are distinct. Next slide. The number one difference between JIA and RA is that JIA is a group of chronic arthritis disorders affecting children. On the other hand, RA is a single condition. Next slide. The International League of Associations for Rheumatology stratifies JIA into oligoarticular, polyarticular RF negative or RF positive, enthesitis-related arthritis, psoriatic JIA, systemic JIA, and any arthritis that does not fit into these categories or corresponds to more than one subtype is considered as undifferentiated. Next slide. The main characteristics of arthritis, internal organ involvement, laboratory markers of each subtype, and adult equivalent are shown in the table. Oligoarticular JIA is characterized by inflammation of up to 4 joints that proceeds as asymmetrical arthritis, predominantly the joints of the lower extremities, such as the knee and ankle. It has high frequency of positivity to anti-nuclear antibody and confers high risk of chronic uveitis. Polyarticular JIA affects 5 or more large and small joints, hallmarked by injury to the metacarpophalangeal joints and wrist. Both RF positive and negative variants have characteristic clinical features. Among patients with RF negative polyarthritis, inflammation can be asymmetrical, but for RF positive, symmetric involvement of the large and small joints of hands and feet is the most prevalent. Seropositive polyarthritis shares similar clinical phenotype, serology, and immunogenetic profile to that of adult RA, and both can occur in the same family. Joint inflammation is very aggressive and erosive. And because of these features, seropositive polyarthritis is generally accepted to be equivalent to RF-positive adult RA, but with onset at less than 16 years of age. The association with anti-CCP emphasizes this relationship. Next slide. Enthesitis-related arthritis resembles oligoarthritis, affecting the joints of the lower limb in association with enthesitis. due to the association with lower limb and sacroiliac joints, enthesitis, uveitis, and the association with HLA-B27, authors have suggested that ERA to be a disease belonging to the group of spondyloarthropathies. Next slide. Psoriatic JIA often proceeds as oligoarthritis or RF-negative polyarthritis and involves more commonly the small joints accompanied by dactylitis, psoriatic rash, or nail pitting. Psoriatic JIA itself is described as a heterogeneous disease where children less than 6 years are more likely to be female, ANA-positive, and predisposed to chronic uveitis, with arthritis involving the wrists and small joints of the hands and feet. However, in older children, disease is associated with HLA-B27 positivity, enthesitis, and axial disease with male predisposition. Next slide. Standing apart from other subtypes, systemic JIA manifests not only with widespread arthritis, but also with a significant range of systemic inflammation symptoms. There is often a high fever and a skin rash. It may also cause inflammation of internal organs, including the heart, the liver, spleen, and lymph nodes. Approximately 10% of systemic JIA patients present systemic symptoms with associated macrophage activation syndrome, or MAS, a potentially life-threatening condition with histopathological features of differentiated macrophages with high hemophagocytic activity. Systemic arthritis also defines the category of patients that were previously labeled adult-onset Still's disease. Next slide. The main hallmark of JIA, as with rheumatoid arthritis, is joint inflammation with tissue destruction. The figure here differentiates the normal joint from an inflamed joint due to JIA. And within the synovial joint of kids with arthritis, the synovial membrane thickens in response to uncontrolled proliferation of synoviocytes and immunocompetent cells, which include T cells, B cells, natural killers, the neutrophils, macrophages, and dendritic cells that infiltrate the sublining layer of the synovium. Hyperplasia and hypertrophy of the synovium causes intra-articular hypoxia, increasing the production of pro-angiogenic mediators and initiating pathological angiogenesis. New blood vessel formation within the synovium increases blood supply and the migration of pro-inflammatory cells into the joint, forming a pathological synovium known as pannus. Next slide. Considering that JIA is a disease of the developing body, kids with JIA are likely to suffer from disruption of skeletal growth. JIA may affect a child's bone development and overall growth, whereas RA does not affect growth and development because the disease impacts adults. Next slide. The heterogeneity of JIA disease subtypes adds complexity to the investigation of cause and mechanism of pathogenesis. Oligoarticular and polyarticular JIA are characterized by autoreactive antigen-specific T cells and high titers of autoantibodies, and typically show strong associations with major histocompatibility complex class II alleles. Breakdown of immunologic self-tolerance involves the MHC class II alleles, suggesting a pivotal role for CD4 T helper cells. Inflammation is considered to be a consequence of disrupted balance between pro-inflammatory Th1, Th17, and anti-inflammatory regulatory T cells. Next slide. The pathogenesis of ERA is driven by HLA-B27-mediated presentation of erythrogenic peptide following T cell activation and IL-23 and IL-17 secretion. Bowel wall inflammation that usually accompanies enthesitis-related arthritis is driven by gamma delta T cells, Th17 cells, and IL-17 and IL-23 production. Enthesitis is triggered by repeated biomechanical stress stimulation, resulting in microtrauma and release of fibronectin, hyaluronan, and other molecular components from the damaged connective tissue. Interestingly, the pathogenesis of late-onset psoriatic JIA resembles ERA, with inflammation in the emphyses and the bowel wall. Early onset psoriatic JIA is characterized by adaptive immune mechanism with development of dactylitis. Next slide. Standing apart from non-systemic subtypes that are known as autoimmune disorders, systemic JIA has been suggested to be autoinflammatory in pathology. There is uncontrolled activation of the innate immune system, resulting in inflammation of monocytes, macrophages, neutrophils, and immature myelomonocytic precursors, and increased production of pro-inflammatory cytokines IL-1, IL-6, IL-18, and phagocyte-specific proteins. In the plasma and synovial fluid of patients with JIA, there is a significant and predominant pro-inflammatory cytokine signature. These cytokines have become targets for treatment of each subtype. Next slide. There is no specific test to diagnose JIA. Clinical symptoms and physical examination findings are key and include signs of arthritis and extra-articular findings. The family history, laboratory markers, and imaging studies such as X-ray, ultrasound, and MRI are used to determine JIA subtype. The slide here shows the clinical and radiographic features of knee monoarthritis in oligoarticular JIA. The knee of an 8-year-old girl shows large effusion involving the joint space and suprapatellar bursa, along with a moderate flexion contracture. Frame B shows post-gadolinium MRI sagittal view of the right knee in a 9-year-old child with knee arthritis. Findings include joint effusion with inflammatory synovial hypertrophy and bone marrow edema. Frames C and D show ultrasound of a knee in a 10-year-old girl with JIA. There is large joint effusion with synovial hypertrophy. The Doppler shows increased blood flow to the synovium. Next slide. The first two images of this slide are from an 18-month-old boy presenting with seronegative polyarthritis. Swelling of the right thumb was associated with clinical signs of intraarticular fluid and synovial hypertrophy, with radiographic evidence of soft tissue swelling, bony overgrowth of the first metacarpal, where the thick arrow is pointing, and premature ossification of the proximal phalange growth center. The third picture shows retrognathia in a 12-year-old girl, while the onset of RF-negative polyarthritis at age 3 years. Joint damage associated with temporomandibular joint arthritis can result in altered physiognomy, including micrognathia, retrognathia, malocclusion, and facial asymmetry. Next slide. Picture on the left shows hand of an adolescent with seropositive polyarthritis. There are swan neck deformities in digits 2, 3, and 4, displaying characteristic extension at the proximal interphalangeal joints and flexion at the distal interphalangeal joints. A boutonniere deformity at digit 5 shows characteristic flexion at the proximal interphalangeal joint and extension T. Deviation at the metatarsal joints is also demonstrated. Shows marked subluxation of the left wrist and mild subluxation at the right wrist. Right shows bone erosions. Next. Children with ERA have inflammation predominantly affecting joints and entices of the lower extremities, which may also eventually affect the sacroiliac joints. It is characterized by a strong association with HLA-B27 and absence of rheumatoid factor. A 15-year-old boy is shown in the position of maximal forward flexion. Note the flattened back, although his radiographs demonstrated bilateral sacroiliac arthritis, but no abnormality of the lumbosacral spine. The other pictures are clinical photograph and MRI demonstrating tarsitis in a 12-year-old boy with ERA. Next slide. The boxed set of pictures on the left demonstrate dactylitis in juvenile psoriatic arthritis. Note the third finger that is sausage shaped, and also the second and fifth toes. The radiograph of the hands from the patient in A demonstrates periosteal reaction in the affected digit. The boxed set of pictures on the right shows cutaneous manifestations. Psoriasis vulgaris on the scalp, scaling behind the retracted ear, and nail dystrophy. Findings include multiple nail pits, discoloration, and early onycholysis. This example shows florid changes, but more commonly, nail findings are subtle and easily missed. Next slide. The first picture shows an 8-year-old boy who had onset of systemic JIA at the age of 4 years. There is symmetrical large and small joint arthritis. He has axillary lymphadenopathy and marked hepatosplenomegaly. Second picture shows a typical rash of systemic JIA. The rash is salmon-colored, macular, and non-pruritic. Individual lesions are transient, occur in crops over the trunk and extremities, and may occur in a linear distribution known as Kebner phenomenon after minor trauma such as scratching. All the pictures I showed you came from our textbook. Next slide. What is the proportion of JIA subtypes seen in our clinics? The table shows results from 2 institutions that cater to pediatric rheumatologic patients. The most common subtype seen in both centers is seronegative polyarthritis at 42 to 47%. In PGH, it is followed by oligoarthritis at 24% and systemic JIA at 14%. In UST, seronegative polyarthritis is followed by systemic arthritis at 26%, then enthesitis-related arthritis at 13.5%. The proportion of RF-positive polyarthritis, the adult RA counterpart, range from 1.5 to 6% only of all JIA cases seen. While about 80% of people with RA have high levels of rheumatoid factor in their blood, fewer than half or even a quarter of all children with juvenile idiopathic arthritis are RF positive. Next slide. Treatment of JIA requires anti-inflammatory and immunomodulatory drugs. The choice of pharmacological treatment depends on the disease type, subtypes, disease severity and damage, associated disease, and family acceptance. Non-steroidal anti-inflammatory drugs are the mainstay of initial symptomatic treatment for all subtypes, and most of our patients do respond favorably with naproxen. In more developed countries, NSAID use in JIA has decreased over time with modern aggressive treatment, including methotrexate and biologics. Other non-pharmacological treatments may include physical therapy to improve and maintain muscle and joint function, occupational therapy to improve ability to do activities of daily living, nutrition counseling, regular eye exams to find early eye changes from inflammation, lifestyle changes that include regular exercise and weight control, getting enough rest, learning to use large joints instead of small joints to move or carry things. And surgery is offered to correct bone and joint deformities for better function and mobility, usually at the time that the patient is in remission. Next slide. Proper treatment helps 50 to 70% of children with JIA experience periods of remission and no disability. Prognosis is generally good for JIA patients. Next slide. Though JIA and adult RA are both types of inflammatory arthritis, JIA is much more than a kid-sized version of adult RA. Rheumatoid arthritis is a debilitating disease with lifelong symptoms, but that isn't always the case for children, affected by juvenile idiopathic arthritis. That will be all. Thank you.
Thank you very much, Dr. Michael T. and Dr. Cherica T. for the very insightful and informative lectures. We have a few questions in the Q&A box, and we will proceed with asking the speakers to answer them. So the first question, I think this is for Michael. Can you expound on the differentiation between erosive osteoarthritis and elderly onset rheumatoid arthritis? Dr. Mike? Dr. Mike, are you there? So if not, let's when Dr. Mike comes on, he'll be able to answer this question. This is for maybe for even Dr. Cherica. This was asked also early on with Dr. Mike's lecture. Can cracking knuckles cause arthritis?
Oh, cracking knuckles per se do not necessarily lead to arthritis. No, it's some sort of stretching your muscles. So some would do that, would feel relief when they do that, but we have to be cautious that it may cause some injuries to yourself when you do that. So not arthritis, but possibly injuries.
Okay, thank you. These are questions for Dr. Mike. Actually, he's answered them. So there's a question, what is the difference between bone cancer and arthritis? Or can arthritis lead to bone cancer? Dr. Mike answered, yes, there is a difference, but it does not lead to bone cancer. Okay. Can you expound on the differentiation between, so that was, he answered it. So Dr. Mike's answer was erosive osteoarthritis is degenerative, while elderly onset rheumatoid arthritis is an autoimmune disease. In your practice, what dose of corticosteroids do you usually start for elderly patients with active rheumatoid arthritis? And the answer is prednisone 10 milligram equivalent. What laboratory tests do you usually do prior to starting RA treatment? So Dr. Mike answered, establish RA diagnosis by having tests for rheumatoid factor, anti-cyclic citrullinated protein, anti-CCP, liver and kidney function tests, chest x-ray, and if with high risk, hepatitis profile. Do you adjust the dose of methotrexate? I think Dr. Mike is now here. Do you adjust the dose of methotrexate for frail elderly patients?
Yes, sir. What I usually do would be to maybe instead of 12.5 milligrams, I'll give 10 milligrams once a week and then increase the interval. Decrease the interval between the first consult and the immediately succeeding for monitoring. So that instead of the usual 8 weeks to 12 weeks, I will try to see the patient in 6 weeks after 6 doses of methotrexate. So I will see whether there is an adverse reaction. And also in my prescription pad, I already put every Saturday and I'll highlight it with yellow just to make sure. Sometimes in the first consult, I put do not take this every day because those are the common mistakes that patients will do. So more than the adjustment of dose, it is making sure that these patients will not overdose because they misinterpreted your prescription.
Thank you. Dr. Mike, again, you mentioned in one of your slides that elderly patients with RA have a high IL-6 and a low TNF compared to young onset RA. Is tocilizumab a better option for elderly RA patients needing biologics?
There is no comparison between the effectiveness of TNF and IL-6 inhibitors among patients with RA. However, there is a study that IL-6 can result to good disease activity improvement among patients with elderly onset RA. Same with anti-TNF. So really, the question would be, what can you give? If the patient has tuberculosis, or number two, the patient has congestive heart failure, then I would give IL-6 inhibitor. And in the because there is really no in the Philippines no guideline that will make you use one over the other, then in elderly patients, I would usually give IL-6 inhibitors first. Especially now, no? Because government hospitals have an excess supply of tocilizumab, those that were not used against for patients who are fighting against COVID. So maybe we can start using that for its original purpose.
Thank you. Thank you, Dr. Mike. Question from an anonymous attendee. What do we do when liver enzymes are persistently increased in RA patients being treated with methotrexate? Do we discontinue methotrexate and shift to other conventional DMARDs or just down titrate methotrexate?
In my answer that I type, I said I will stop. I will stop. Sir, maybe just like you, we will stop because of the dictum, first do no harm. If we think that it is because of methotrexate, we stop and monitor for disease activity improvement or worsening. Because if there is worsening, we try to intervene immediately with another treatment option. If not, we'll just wait for the symptoms of transaminitis to resolve.
Thank you. So thank you, Sir Mike, for the informative lecture. Can early onset RA coexist with gout? Elderly onset RA coexist with gout, CPPD, or erosive hand OA? Is it worthwhile to proactively screen our patients for RA?
Yes, we can proactively screen for RA, but screening does not mean that we will be taking rheumatoid factor, anti-CCP, CRP. And that can be done by clinical observation, clinical questioning. And if we find that there is a morning stiffness, the arthritis, instead of being episodic, becomes chronic, persistent, and symmetrical, then that's the time we say the probability or the pretest probability of it becoming an elderly onset RA is now high, that I'm going to get rheumatoid factor. Because as I mentioned in my lecture, it can be from 10 to 30% positive. And that can lead to a false positive information that will make you treat with methotrexate instead of colchicine, allopurinol. Then you will give methotrexate, and that will result to more problem than the patient deserves.
Thank you. This is an interesting question. What if there is a reaction from the over-the-counter drugs that an elderly person using to treat rheumatoid arthritis, which is not prescribed? What will you do if she refuses to see a specialist?
Because I am the specialist and she refuses to see me, then we have technically no contact. So
Thank you.
there's nothing
Thank you,
I
Mike.
can do. For you,
Very
maybe,
clear.
you see, much of our patients' decision against going to specialists is due to misinformation or even malinformation. No? So what we would like to see is our general practitioners, our primary care physicians, empowered to explain the intricacies of presentation and complications of this inflammatory arthritis, so that the patients will understand. Because I do not believe the what we usually say, the matigas ulo. It's really just that they do not understand, and they have fears. So the moment that we connect properly, patients will do as we say, because they will believe what we say. In fact, the reason the patient sees you is that he believes in your advice. Maybe just not that much yet to be weaned off your care and going to another physician. But if you say that, yeah, I will continue to manage you, and I will make sure that I contact the rheumatologist, we'll talk to him together, and I usually allow that. No, in fact, when a primary care physician refers to me, my immediate response will be to inform the primary physicians. I'll take a picture of the referral. I send it to the physician referring to me with a note, thank you, I'm taking care of her now. And then I might even take a picture of us too and show it to the referring physician, because that establishes connection.
Thank you, Mike. Very, very excellent words of wisdom. This is for Cherica, Dr. Cherica. Aside from clinical presentation, are there any tests available that can differentiate the different types of JIA?
Yeah. Imaging studies can aid in assessing, actually answer that, in assessing primarily axial joint involvement. So it could help you in the diagnosis. Other tests such as inflammatory markers and serology are used more for prognostication rather than diagnostic.
Thank you. For us GPs, general practitioners, what are the subtle initial signs and symptoms that we should be aware of to detect JIA so that we can refer them ASAP?
So it depends on the age of the child. So if they are babies or toddlers, so if there are changes in the milestones, you're supposed to expect that they could walk, and then that child would rather crawl than walk. So there are changes in the milestones. Maybe there are problems already in the limbs or the joints of that child. But for older children, if there's persistent joint pain or swelling or limitation of movement or even prolonged fever for systemic arthritis, you can refer them to us.
Thank you. Is there a special diet for JIA?
That I know of, better to encourage healthy eating habits.
Thank you. Is it true, so this is still with diet, is it true that legumes and other nuts are associated with rheumatoid arthritis? Is there a need to limit or to refrain from the intake of legumes or nuts?
No, sir. In fact, these are vegetable proteins and would be a good substitute to animal-based protein. So these are important part of our diet, and there's no association to any type of arthritis, except if you overconsume anything and you gain weight, then you develop osteoarthritis.
Thank you, Mike. And Cherica, any comment on this question? Are beans like peanuts,
Oh.
etc.?
No, not really. Studies show diet is not much contributory factors to develop GI or even in the persistence of arthritis for these kids.
Thank you. Do you give folic acid to patients taking methotrexate?
Yes.
Yes.
Okay, thank you. Is it possible to acquire RA as a sequela effect from an adverse reaction from a drug? Talking about autoimmune response developing into rheumatoid arthritis? From Dr. Ismael Perez.
That would be difficult to establish.
Okay. So the cause and effect we cannot be certain. Okay. Anonymous attendee, what proportion of your patients are JIA patients transitioned from pediatric care, and how is the prognosis? Thank you. This is for Dr. Cherica.
I think that's for Mike T.
It's
Ilan na ba
for Mike
natin?
T. Okay. How many do you get? How many of your patients are transferred from Cherica to Dr. Mike?
Maybe I have about 15, but I don't know the base. 15 JIA and even more young onset lupus, because the patients with lupus, when they graduate from her care, maybe I already have about 30 of them over the years.
Thank you. Good husband and wife team there. For JIA patients in remission, do you still maintain them on immunomodulators?
We try to down titrate the dose, or if it can be totally removed or discontinued, the better. As what I've mentioned, GI has good prognosis. Some do reach remission and off medications.
Thank you. Would you recommend a low carb diet to prevent RA? Since this is a good, actually very relevant issue. Since one doctor vlogger, I lost the question. Many questions coming in. Since one doctor vlogger promotes this to cure the inflammation inside our body to achieve wellness. Mike or Cherry?
I'm not sure, sir.
Yes.
I cannot
not
answer
sure.
that with authority.
Okay. That is a valid answer. Good afternoon. For patients with JIA but with renal impairment, which DMARD could we offer to these patients? Cherry?
I might need the help of a nephrologist in assessing the function of this kid's renal activity. So we need
Okay.
to really talk about it with the patient.
Biologic agents, sir, we can give even if there is renal impairment. Methotrexate can be given, but with adjusted dose. What's not to be given is not DMARDs, but NSAID and coxibs. I would rather give a combination tramadol and steroid to address analgesia and inflammation for these patients with elevated creatinine and low creatinine clearance.
Thank you. This is also another very relevant question. Can chiropractic therapy help in arthritic patients?
In itself, sir, having arthritis means you're already in pain. And among our fellows, they will hear me repeatedly say that in examining a patient, sometimes those with inflamed joints will appreciate if you don't touch them too much. You first try to examine by inspection. So you see redness, swelling, and just ask, is it painful? Now imagine that kind of patients, you're trying to avoid hurting, being touched by a chiropractor with an intention to pull the joints, pressure the joint. Imagine the kind of pain that they will experience. Now they will say, but the patient already has low level of disease activity. Then I will counter. Then what's the point of referring? Because by the time the medication that a rheumatologist or practitioner, or what call this, the general practitioner or primary care physician they have achieved the goal of decreasing joint swelling. That's why it can already be manipulated. And maybe in other muscle pain, fibromyalgia, that is a possibility. But for someone with inflamed, tender, swollen, painful joint, I cannot imagine the patient appreciating that kind of manipulation. It may even result to hemarthrosis.
Yes.
And we have seen a lot of shoulders having blood after tapping because of poor practice in manipulation.
Thank you, Dr. Mike. And I think I just want to add that I would actually refer the patient first to a physical and rehab medicine doctor for proper evaluation of what kind of therapy the patient, physical therapy, occupational rehab medicine the patient needs to undergo. Question, how long do they take prednisone? I guess this is for any of the arthritic syndromes that you've mentioned, RA or JIA. You can just answer.
In children, as much as possible, we shun from using prolonged steroids use.
Thank you.
Average would be 3 to 6 months, sir. Because by the time I would have escalated the dose of methotrexate or introduce a biologic agent to the patient who's not responding to target. And the target is DAS28 less than 2.6.
Thank you. I just want to ask, is it safe to wear TED stockings for patients who have RA? Thank you. From Angelita Tabuso.
Yes. Yes, it is, as long as the patient can tolerate and there is no severe swelling of the ankle joint or the knee joint. Because then the act of putting it is going to be a real problem.
Okay. From Catherine Alarma, how is rheumatoid arthritis different from reactive arthritis?
Reactive arthritis is usually termed as can't see, can't pee, and can't climb a tree. So there's uveitis or scleritis, can't pee, there is UTI symptoms, and can't climb a tree, there's joint pain. And it is associated with a previous history, proximate history of infection, either STD, diarrhea, or UTI. While RA will just happen. It's autoimmune.
Thank you. I think this was partially answered. In patients with renal impairment, what is the best biologic that can be given?
So any biologic agent is not contraindicated among patients with elevated creatinine or low GFR.
Okay, thank you. This was already answered also partially. For patients with JIA but with renal impairment, which DMARD could we offer to these patients? I think that was answered earlier.
Yes, sir, answered na yan. Any.
Yeah, good.
It's just that we will adjust.
Adjust the dose. Yes. I'll only ask two more questions because we're running out of time. Which is the more cost-effective between a tablet or injectable medication for rheumatoid arthritis? Thank you. From Tim Dalde.
Tim, that would be the drug that can result to good quality of life. You see, cost effectiveness, there is a thought process that it is value-based care. Even if it's cheap, but it is not achieving the target, it's useless, it's expensive. But it may be high in cost, but it is able to achieve the target, then it becomes a valuable medicine. So it has to be a decision that you make with your patient. How much can they afford? That will not impact much on the financials of the family, while he's able to function properly and minimize the impact on quality of life.
Thank you. This is also very relevant. How common does RA develop after being afflicted by COVID-19?
Yeah, I have a report last year on a transient rheumatoid factor positive patient with oligoarthritis. But after treating with short term steroid, low dose, the patient zero converted. So in some studies, it has been reported, not too often, and there is not much data to show the percentage because you have to know how the base, no? But it has been reported maybe 3-6 in every report. So it happens. In our case, it was transient rheumatoid factor positive, but it also has been reported after vaccination. So we don't know. The number of people vaccinated is so high. In the Philippines, it's already 80 million. So whatever happens may not be correlated, but the natural times that patients would really have the natural prevalence with or without vaccination. So
Okay,
it's
thank you.
difficult to put a cause and effect to that.
Thank you. And one last question. Are there certain medications, maybe corollary to the previous one, are there certain medications, vaccines implicated in the development of rheumatoid arthritis or JIA?
There are some antibiotics or even live vaccines implicated, but there is no clear link between these drugs or vaccines to the development of JIA.
Thank you. One last, does functional medicine help RA patients in terms of alleviating or even curing the condition? Thank you.
Functional, ano sir?
Medicine.
Functional medicine. This I think is a lifestyle type of medicine. I know that there might be followers of this in the group.
I'm not an authority to answer that, sir.
Okay, that's a fair answer. So thank you very much, Doctors Michael and Cherica Tee, for answering those questions and your talks, your excellent talks. I'm sure our audience learned a lot from you today, and I'd like to thank you and our audience for the very interesting questions that you have posted. Very briefly, we learned a lot from you, Mike, about elderly onset RA and how it's differentiated from young onset RA, and that the elderly have different issues from the young, from malignancy to different types of arthritis, CPPD, comorbidities, to geriatric syndromes, polypharmacy. These are all the things we should keep in mind, especially when we when we encounter patients who are who are elderly, and you diagnose them with rheumatoid arthritis. Very interesting, actually, is that cigarette smoking in the 70s, which was very much prevalent. Everyone was smoking then, and we are seeing the patients now who probably smoked back then, and this is a risk factor for it. You mentioned genetics. You mentioned the frail elderly, which we should think about. Bedridden patients, risk of infection, and of course, increased mortality. And ultimately, we want to maintain quality of life for all these patients with targeted treatments, and hopefully they will actually get better. You mentioned something about ultrasound super microvascular imaging and power Doppler imaging, which are also being used very actively today, and hopefully we can strengthen our data on that. And for Dr. Cherry, I has noted very much and was very appreciative that you're able to differentiate the different syndromes of JIA, of which RA is just one of them. And there are many syndromes that we have to look for. And I do see, as an adult rheumatologist, I do see a lot of similarities between adults and pediatric arthritic conditions. However, being children, they're growing human beings, so their needs are also different. And so that's about it. I think we had a very good discussion today. And if there are no further questions, I'd like to thank again our speakers, Dr. Michael T. and Dr. Cherica Tee, for a very, very enlightening presentation and discussion. We'd also like to thank the Information Management Service Network team of UP Manila and our sponsor, Pfizer. So thank you all for joining us. We hope to see you all again on October 20 next month for another informative and timely lecture regarding ankylosing spondylitis. So have a good afternoon, everyone.